I'm Adrienne Young, the Research Coordinator of the Nutrition and Dietetics Department at Royal Brisbane and Women's Hospital. And today, Jane Musial and I will be talking you through the implementation and evaluation of the RBWH and QUT model of care for patients with type 2 diabetes. So we'll be doing this as a bit of a team act. I'll talk you through the clinical problem and what is the evidence for managing this problem, and then Jane will talk to you about how they developed the model of care, how they implemented it and evaluated it. Before we start, we just wanted to acknowledge our QUT partners, and in particular Bonnie, who was our research student who conducted the evaluation, and Robbie Mullins, who works in the QUT health clinics. So our clinical problem is this type 2 diabetes epidemic. We know that it's highly prevalent and it costs the Australian health system a huge amount of money each year. And this highly prevalent problem then of course places a high demand on our health services. And we know from national data sets that diabetes is the third most frequently referred condition to medical specialists and the second most frequently referred condition to allied health services and hospitals. And so all of these referrals into our health system can often result in long wait lists to access specialist care. And there are studies that suggest that this results in deteriorating glycemic control. Locally, our problem was similar. We know from our local waitlist data that around half of our CAT2 patients are seen within the recommended timeframes, which means that the other half are not receiving intervention in a timely manner. The way the RBWH diabetes service is set up is that patients are referred in and are seen by the endocrinologist, the dietitian and the diabetes educator with no regular or structured input from an exercise physiologist, optometrist, psychologist or podiatrist. So there are national and international guidelines and standards of care which outline good evidence for how we should be managing patients with type 2 diabetes. And these guidelines recommend that all patients with type 2 diabetes receive diabetes self-management education, and that this should be multidisciplinary in nature and delivered either individually or in a group setting. Now these guidelines are a really good starting point to understand what the evidence is, and they're an important synthesis of that evidence. But I think as clinicians we really need to be able to understand how the guidelines were developed, how the studies that inform the guidelines were conducted, so that we can really interpret and critique the quality of the studies and how this might then apply to our specific patient group and local context. So for this study, we've selected one systematic review that was referenced in the most recent ADA standards to talk you through using the checklist that Barbara presented in her presentation. So this paper is a systematic review with meta-analysis, and it compares group-based education to routine treatment for type 2 diabetes. This paper builds on an earlier Cochrane review and was conducted by researchers from 2 universities in Norway. So if we consider the first few screening questions from the CASP tool, we can see that this review paper is highly relevant to our clinical problem of high demand for services for type 2 diabetes. And it had a very defined clinical question, so it was focusing on adults with type 2 diabetes who either received a group-based education or routine treatment, was sitting on wait lists or received no intervention, and they had a range of relevant outcomes that were measured at a range of time points, and they only included randomised controlled trials. So based on these facts, we can see that it is worth having a closer look at this paper. If we work through that CASP checklist that Barbara presented and read through the paper, we can see that the authors undertook a comprehensive search of the database and reference list and checking with experts. They used the Cochrane risk of bias checklist to assess the quality of the individual studies, and it's important to remember that most of the studies had moderate risk of bias, so there was only a couple that had low risk of bias. The literature search and critical appraisal were done by 2 different people independently, who then came together to compare findings and resolved any issues by a third party. And this is a much more rigorous process than just one person finding all the papers and appraising them. So we've got a little bit more confidence in the process they used. They used statistical testing to look at the variation in the results between studies, or the heterogeneity. And where the results were inconsistent, they conducted sensitivity analysis. They also did some subgroup analysis, so they looked at the results of studies based on how the group programs were delivered, the attendance rates, and the baseline glycemic control to see whether these factors impacted on the results. And they also did some sensitivity analysis based on some of the issues with the study design, so sample size, risk of bias and dropout, to see if these affected the results as well. So when we look at the results section of the paper, because this study had multiple outcomes and time points, I think they had something like 20 different outcomes. So instead of presenting individual forest plots, they summarised the meta-analysis into a table. So I've just kind of taken a screenshot of half of one of their tables, and if we zoom in on HbA1c at 6 months, they looked at the mean difference between the groups. So they looked at HbA1c at baseline and the end of the program and compared the difference between the patients that attended a group program versus an individual program. There were 13 studies that looked at HbA1c at 6 months, and we can see that when they pooled all of the results from these 13 studies, that there was a reduction in HbA1c of 0.44, and that the 95% confidence interval ranges from negative 0.69 to negative 0.19. So most of the results sort of lie in this range here. So that's a significant, clinically significant reduction in HbA1c, and it's also statistically significant. And there was a bit of heterogeneity there, and so they took out the studies that were causing some of the conflicting results and found that the findings still stood. So when we look at all of the results from that study, at all the different time points, there was good evidence that the group education for type 2 diabetes improves glycemic control. The results weren't as convincing for some of the other outcomes, so for weight and for some of the more clinical outcomes. But it still suggests that using group programs might be a way of improving glycemic control, and therefore might be a strategy we could use to manage long wait lists for the RBWH diabetes clinic. So the final two questions in the CASP checklist touch on whether we can apply these study findings to our local population. And most of the studies were done in similar countries to Australia and quite similar patient groups to those that come through our clinics. And are the benefits worth the harms and costs? So there are clear benefits in terms of patient and health service outcomes. However, there is a cost of delivering this extra intervention. There's no extra resources to be providing this sort of intervention, and no capacity within current workload. So we needed to think a little bit creatively about how we could be providing this better service, where there's good evidence for this, but without having to create new positions and spend more money. So this really led to the QUT RBWH clinic model. So I'll hand over to Jane to talk you through this.
Thanks, Adrian. So as a result of the problem identified and a review of the literature, a new multidisciplinary diabetes outpatient model of care was developed with QUT and RBWH and implemented as a pilot at QUT in 2016. It was a 10-week multidisciplinary program for patients who were referred to the RBWH diabetes service, and it was delivered by both RBWH and QUT staff and students, and represented a new partnership between Royal Brisbane and the Queensland University of Technology health clinics. So how did we implement the program? We started off by assessing the current services and problems. So we really had a good look at the waitlist data to see how extensive the problem was. Once we were convinced that we did have a problem, we looked at other solutions that have been implemented to manage long wait lists and other alternate pathways for outpatients, such as those conducted by physio. We looked at existing services for diabetes across the state. We had a good look at the literature, and we conducted patient surveys. We then approached QUT with a possible solution of running a clinic in conjunction with their students. which they agreed to. So once we had an agreement, in theory, we established a steering committee to oversee the development and implementation of the pilot, and we designed a model of care. And then we developed a MOU between the two sites for the pilot. We then implemented the pilot with 10 patients commencing the program, and as mentioned, it was delivered by both staff and students from the two facilities, and it included input from dietitians, exercise physiologists, diabetes educator, psychologists, optometry and podiatry. The first week of the program included extensive individual assessments conducted by nursing staff and exercise physiologists. This was then followed by 7 weeks of group exercise and education. And at week 9, we conducted some further individual assessments. At week 10, we held a multidisciplinary case conference without the patients to determine their follow-up after the completion of the program. And these are just some happy shots of some of the participants and exercise physiology students in action. So what were some of the strengths of the program? It represented a coordinated multidisciplinary program and provided the opportunity to try some lifestyle intervention before patients were seen by specialists in a specialist outpatient clinic. It was led by dietitian and nursing staff and represented interdisciplinary learning opportunity for both students and staff. So it involved input from a range of different disciplines, and it provided a partnership between a tertiary hospital and the university. In terms of barriers, communication and clinical data sharing between two large facilities provided some barriers. There were some staff changes that occurred during the planning stages of the pilot, which meant that we needed to continually update new staff, provide further communication, and sometimes renegotiate previously agreed terms and conditions. And collecting large amounts of data in a consistent and accurate fashion was also represented some of the barriers that we encountered. In terms of evaluation, we evaluated the program from an attendance point of view. So we looked at the number of patients who attended the program and completed the program. We looked at patient, staff and student satisfaction using validated tools, and student learning readiness for interprofessional learning. We collected a large range of clinical data at baseline, completion of the course at 3 months, and we will also collect data at 12 months. This included anthropometric data, biochemical and clinical data, physical activity, dietary intake and quality of life. And importantly, we looked at the impact on the diabetes waitlist at Royal Brisbane. So what were our outcomes? Out of the 10 patients who commenced the program, we had 9 patients complete the program with a high attendance rate. Of those 9 patients, all the patients reported high satisfaction with the program, and in fact requested longer education sessions and further education sessions in the future. 6 of the staff were surveyed, and of those 6 staff, they also reported high satisfaction and indicated that the program was an effective way of providing a multidisciplinary service and represented a partnership between 2 facilities. Students were also satisfied with the program and suggested it provided a good opportunity for them to observe other allied health members, and it helped to increase their clinical knowledge. In terms of clinical outcomes, all the patients lost weight. Most of the patients had a reduction in blood pressure. We had at least half the patients improve their lipid profiles, and all the patients increased their physical activity during the program, and the majority of the patients also improved their dietary intake. We need to be a little bit mindful of these results. Given that it was a pilot of invited patients, it may have represented highly motivated patients to start with, and we need to consider whether that's going to be applicable to the general population. We were particularly encouraged by the outcomes with respect to weight, and believe that that is a combination of, one, having a highly motivated group to start with, but also weight loss was emphasised as an important goal throughout the course, as that has positive impacts on diabetes management, and it was tackled from both a physical activity point of view as well as diet. So it was a reasonably significant focus of the program. In terms of the waiting list, all the patients were removed from the Royal Brisbane Diabetes Dietitian wait list, and only 2 of the patients required further appointments with the endocrinologist at Royal Brisbane Hospital. So the program successfully created a partnership between Royal Brisbane and QT Health Clinics. It enhanced the student experience and provided a interdisciplinary practical experience, and is an effective way to address long wait lists for patients with type 2 diabetes while leading to improvements in clinical outcomes. And these outcomes are consistent with the literature that we had reviewed prior to commencing the development of the program. Where to from here? We're in the process of finalising another MOU to continue to run the program on an ongoing basis, and we have 3 programs planned for this year. We will continue to evaluate the program and disseminate the results at conferences and peer-reviewed journals. But we do need to consider alternative funding options to be able to sustain the program. And possible options for that include Medicare rebates. So what have we learnt, and what were the positives? Using good evidence to design the model, it gave it credibility and I think improved confidence in the program. We learnt that you need to be very patient in developing a program between 2 facilities, and that thorough planning is really important with good communication. Doing a MOU and ethics application, while tedious at the time, proved to be very, very beneficial, because it ensured that we were very clear about what we were trying to achieve and provided enough detail so that all the stakeholders were also aware of what we were trying to do. We rang our patients prior to commencing the program to give them some information about what to expect, and to remind them of appointments, which, while very time consuming, I think really had a positive impact on attendance. Having clear role clarifications and expectations is really important when you're running a program with a number of different disciplines involved, and using validated tools help to increase the credibility of not only the program but of the results of evaluation. What wouldn't we do again? We wouldn't collect so much data as it is very time consuming, and we need to have a look at the current data that we have and then decide, what is of value and what is important, so that we can rationalise it for the future. So in conclusion, I think using research and evidence to design new programs to address long wait lists or clinical problems is a good way of moving forward in terms of improving service delivery in the future.